Hello, and welcome to another episode of Cracking Addiction with Philippe Naren and Fergal Armstrong. In the episode of Cracking Addiction today, we're going to be following on from our earlier episode on cocaine and talking a bit about some of the acute toxicities with regards to cocaine, as well as some of the metabolites of cocaine and some of the adulterants that are used or mixed in with cocaine. So Fergal, what are the three common metabolites of cocaine?
Yeah, so I suppose when you're talking about metabolites, you also need to think about the kinetics. So if we just go through the absorption, distribution, metabolism, and then I suppose excretion, we can talk about the metabolites in that context. So we know that the bioavailability of smoked or inhaled cocaine is over 80 to 90%, but we're not really sure what the oral bioavailability is because it's not really used orally, is it? But the problem with cocaine's bioavailability via mucosal surfaces is that because it's also a potent vasoconstrictor, that action in itself delays its Tmax, so the delays the peak rate of absorption. It's metabolized by the liver by various enzymes, and it has got various active metabolites, which we'll discuss in a second. And then it's got urinary excretion of some of those metabolites. There's also some excretion through other mechanisms. So if we go to the metabolites, the two main ones are benzyladenine and methyladenine. Benzyladenine is the metabolite that is excreted in urine, and when we're doing urine drug screens, that's what we're actually testing for. Methyladenine is found in plasma. There's another metabolite, which is the metabolite of an interaction called a trans-esterification reaction, and that interaction occurs between alcohol and cocaine. And when you get that reaction in the body, you end up with a product called cocaethylene. Now, if we go to half-life, the half-life of cocaine is about 90 minutes. The half-life in plasma is about 90 minutes. The cocaethylene's half-life is very prolonged, but it is equally as toxic in terms of its ability to vasoconstrict and therefore cause ischemia, strokes, and heart attacks. So you have this exposure to a prolonged risk if you co-ingest alcohol and cocaine. So you get the side effects or the risk of side effects of cocaine, but it's much more prolonged. There's another couple of metabolites. There's one called andromethyladenine, and there's another metabolite called norcocaine. I suppose if we go back to the metabolites again, I mean, I'm just checking some notes here just to make sure I'm not saying anything wrong, but benzyladenine, it does the vasoconstriction. And so remember, we're talking about the toxicity of vasoconstriction causing ischemia, strokes, and heart attacks, and cocaine-associated chest pain. Benzyladenine is not a psychostimulant. It just causes side effects, doesn't make you feel great at all. Methyladenine is a vasodilator and an anticonvulsant, so it's actually good for you. And androadenine methyl ester is a muscarinic agonist and causes bronchoconstriction. And as I've already said, cocaethylene causes vasoconstriction, but at a much more prolonged time frame because it's got a longer half-life than cocaine.
That's fascinating, Fergal, and it's really important to emphasize as well, especially talking about cocaethylene. I've seen some numbers where we talked about how quick cocaine's action is, but I've seen some numbers where cocaethylene can hang around the body for around 13 hours or so. So it really is that prolonged exposure to a toxic substance that can cause significant harm to people. So that combination of alcohol and cocaine really is a lethal combination.
So that begs the question then, right? And I get asked this frequently. What's the safest way of coming off a cocaine high? So if we're looking at a harm reduction model, how do you come off a cocaine high? Because a lot of people use alcohol for that purpose. They get high on cocaine, and then when they want to calm down, they drink alcohol. So what do you say? What's the safest way of coming off a cocaine high if you're going to avoid alcohol?
If you're going to avoid alcohol, I think in a supervised setting or with medical supervision, one could use benzodiazepines as one does with other stimulant medications such as methamphetamines. So that would potentially be a medication that I would utilize in this setting as well. One should also remember that the half-life of cocaine, as we've mentioned in the previous episode of Cracking Addiction, is also quite small. So essentially one could also just manage it symptomatically and just treat the symptoms that one sees during the withdrawal.
Yeah. So you're giving the medical model, right? So I get asked by patients, so when I'm at a party, doc, and I'm high as a kite on cocaine and I want to calm down, and you're telling me, doc, not to drink alcohol, what other illicit drug can I take to come off a cocaine high safely? So I say illicit benzos is the first choice, and then secondly, cannabis. So I'd rather someone use illicit benzos with somebody else, of course, to never use on your own. That would be the first rule of harm reduction. But if you're going to use a drug and you want to come off a cocaine high, illicit benzodiazepines and then illicit cannabis. Those, as far as I'm concerned, from a harm reduction model, those are the two methods that I encourage to come off a to come off a cocaine high, because you're avoiding alcohol and you're avoiding the toxicity associated with cocaethylene. So I, as a doctor and as an addiction specialist, am recommending people to take illicit drugs. What do you think to that?
I think from a harm reduction point of view, one really has to look at what one's trying to achieve. And we've talked about this in previous episodes and also on episodes when we discussed harm reduction. Harm reduction is about reducing harm, and if one can reduce harm, it doesn't eradicate harm, but if one can decrease potential severe effects, you have to speak the patient's language and also utilize tools that the patient has available to them. So you have to be practical in addiction medicine. I think you really have to kind of meet the patient where they're at in many situations. Now, I guess segueing a bit from this and talking, I guess, about some of the acute toxicities of cocaine, and I guess going through some of those clinical manifestations. We touched a bit on some of these in the previous episode, but just to reinforce this, could you tell us, Fergal, again, what some of those cardiac and neurological manifestations of cocaine toxicity could be? Because those are quite important for us to re-emphasize and be aware of.
So I think of cocaine toxicity as mainly, but not exclusively, mainly three organ systems: the brain, the heart, the lungs. Right. So when we're thinking about the brain, we've got to understand that cocaine is a vasoconstrictor. So you get all the side effects of cerebral vasoconstriction, strokes basically, or infarcts, TIAs. You've also got to understand that cocaine is a stimulant, so it's associated with a hyperglutaminergic state, so seizures, hypothermia, right? So really, fundamentally, strokes, seizures, and hypothermia. That's what I think of. Now, of course, when you're thinking about hypothermia and psychomotor agitation, you also then have to start thinking about rhabdomyolysis, which is the melting away of muscles, and then, of course, renal toxicity. So that's the segue to renal. And then when we think about the heart, we think about vasoconstriction again, and we think about this condition known as cocaine-associated chest pain. And of course, when we're thinking about cocaine-associated chest pain, there's a couple of things to say about that. First of all, the ECG changes of ischemia that we would normally interpret as being associated with someone having a heart attack, i.e. ST changes or Q waves, etc., etc. These occur in cocaine-associated chest pain without cellular damage. So even though you might have ischemia or infarct changes on an ECG, you cannot rely on those changes to make a diagnosis of myocardial infarction in the context of cocaine-associated chest pain. You have to have enzyme evidence or enzyme rises. And the second point to say about that is, we would use beta blockers. It's part of our management of angina or hypertension, right? You shouldn't use beta blockers in the context of cocaine-associated chest pain, because if you do use beta blockers, then you've got this unopposed alpha adrenergic activity, which worsens the vasoconstriction and makes things worse. So again, we're going back to the use of benzodiazepines as first line for cocaine-associated chest pain. So we've talked about the brain, then the heart, and then the next organ is the lungs. So of course then we've got crack lung. So when we're talking about the damage to the lungs, we're talking about inhaling crack of freebase. And of course, then you can have spontaneous pneumothorax. Then you can have spontaneous pneumopericardium. Then you can have spontaneous pneumomediastinum. So you can have these spontaneous pneumo diseases. Then you have crack lung itself, which is an inflammatory alveolitis or a hemorrhagic alveolitis. And then, of course, as I've already said, some of the metabolites of cocaine are also potent vasoconstrictors. So methylagonine is a potent bronchoconstrictor.
Indeed. And I think it's one of those things where those are a lot of organ systems that have been listed and that can be affected. And we've also mentioned the risks of cocaine exposure while a woman's pregnant and the risks of placental abruption, intrauterine growth retardation, growth restriction for the fetus. And also, Fergal, you mentioned in the earlier episode of how one of the medical uses of cocaine was as a mydriatic, so a pupil dilating agent as well. And there's always risks of acute angle closure glaucoma with those agents. So again, it's pretty much one of those drugs that could potentially cause complications everywhere there's a blood supply and blood vessel issues, and as well as organ system issues.
Yeah, that's a good point about the womb. The uteroplacental circulation is not auto-regulated, so it's entirely dependent on blood pressure, and so therefore it's very sensitive to vasoconstrictors, including cocaine. And of course it is associated with placental abruption. And of course subject also to secondary to the vasoconstriction, you've got this IUGR, the intrauterine growth retardation.
And I guess what we've done is we've talked about cocaine itself, but we haven't actually talked about any of the adulterants or cutting agents that are associated with cocaine. Yeah. And usually there's three common ones, and we'll go through them one by one. Yeah. But we'll start off, I guess, Fergal, with Levamisol, which is an antiparasitic medication normally, but it's frequently cut with cocaine, and it's got quite a few complications associated with it. Would you care to elaborate on those complications?
So Levamisol is actually, it's an antihelmintic, but it's also used in colorectal cancer. It's a chemotherapeutic agent for colorectal cancer. And for some reason, it is actually used to cut down cocaine powder. And I don't actually know why. Do you know why Levamisol is used as a cutting agent?
I don't, to be honest.
So anyway, it is nonetheless used as a cutting agent, and I'm presuming it's basically because it looks the same when it's crushed up. It looks the same as cocaine powder, and so therefore you can dilute the cocaine and sell more gram for gram. But of course, it's associated with toxicity, and the two main toxicities that I worry about when I think about Levamisol as a cutting agent are firstly agranulocytosis and B small vessel vasculitis. So it can knacker your immune response. You're more prone to infections, and you can get these vasculitic conditions. So your blood vessels, your small blood vessels, get inflamed, and that can cause bruising and internal organ damage, including renal damage. So, yeah, that's Levamisol. Are there any other harms that you're aware of with Levamisol?
So Levamisol, I always struggle with that word, can also cause a vasculitis as well, and it can cause skin ulceration and necrosis as well. And it can also cause leukoencephalopathy, which is essentially a white matter disease of the brain. So those have been other associations, but agranulocytosis, as you've mentioned, is a life-threatening condition potentially. It really can depress one's immune system, and it can be fatal if it's not treated. So there's a lot of significant complications with Levamisol.
So just to summarize, so we've got agranulocytosis, which is a reduced white cell count. We've got the vasculitis, which can affect any organ system, in particular the kidneys. And we've got leukoencephalopathy, which is a disease of white matter. So those are the pathologies associated with Levamisol. What's the next adulterant that is commonly used?
The next one is a beta agonist called Clenbuterol. Again, it's a common adulterant, and I guess the common side effects or interactions I've seen with Clenbuterol or read up on Clenbuterol are mainly those related with hyperglycemia and hypokalemia. Are you aware of any other significant issues with Clenbuterol?
Well, it's used or it's misused as a cutting agent amongst bodybuilders. Now, when bodybuilders use cutting agents, they're not talking about diluting cocaine. They're talking about stripping the fat off them. So Clenbuterol, there's a theory that Clenbuterol has a partial activity on stimulating lipolysis in fat cells, and so that's why bodybuilders will use it to try and get really, really reduced fat content, so they get heightened musculature. So that's why that's the other reason why that's the other reason by which Clenbuterol is misused. Now, in terms of cutting agents, it can also theoretically induce lipolysis, but that's not the biggest issue. The two main things are the hyperglycemia and the hypokalemia. Now, I mean, a high sugar is not that serious, but a low potassium can have serious consequences. Would you care to elaborate on that?
Potassium, if we remember nothing else, can cause heart arrhythmias. So we really do need to be aware that this can cause cardiac arrhythmias. And we already have mentioned cocaine by and of itself can predispose someone to heart arrhythmias. So basically you've got two agents that are acting in concert to affect your heart. So one does have to be super careful with regards to this.
So let's just clarify that. Why does cocaine cause heart arrhythmias? There's two mechanisms for that.
So it's a sodium channel blocker, and it also inhibits the reuptake of noradrenaline and dopamine.
Yeah, all right. So those two effects actually increase the arrhythmogenicity of the heart, so it predisposes to heart rhythm. And then of course, you throw into the mix a low potassium, and then you're getting a recipe for disaster there, aren't you?
Indeed, you are.
Yeah.
And I guess if we were to go to probably the last common adulterant, and possibly one of the most dangerous when used with cocaine. And we're probably talking about fentanyl here. And there have been numerous cases, particularly in the media, of cocaine being cut with fentanyl. Could you explain to us, Fergal, why this is so dangerous and why it is life-threatening?
So I suppose we need to go back a little bit because, 15, 20 years ago, it was really common to inject heroin and cocaine together. And that was known as speedballing. And so there's been always this underground movement of really playing around with substances. So fentanyl, as we both know, is a synthetic opioid, so it's much more potent than heroin. Now fentanyl, there are a number of reasons why you would want to cut fentanyl, or you would want to use fentanyl to cut cocaine. So firstly, it's produced synthetically and produced in massive quantities. So I'm sure there's economies of scale where it's actually cheaper to produce fentanyl than it is to produce cocaine. So therefore, if you adulterate cocaine with fentanyl, you get a more cost-effective product. But from a dynamic point of view, fentanyl is a very potent mu agonist. So if you want to get high on an opioid, fentanyl is a great opioid to get high on. But the half-life of fentanyl is up to 8 to 9 hours, right? Whereas the half-life of cocaine, as we've already said, is only 90 minutes, 1.5 hours. So again, remember we're talking about how to come off a cocaine high. So, you want the depressants. After you've had the stimulation, you want to be depressed. So that's why, if you're taking cocaine, which is a stimulant, you're high, you take, the safest thing to take is a benzodiazepine to get down again. But if you think about the half-lives of cocaine and fentanyl, if you take your mixture, you get high in the cocaine, which only lasts 90 minutes or so. And then you have this prolonged depressive or opioid-induced depression due to the prolonged action of the fentanyl. So that then, I suppose, mimics the high and the low that you want when you're using illicit substances. So there's a kind of an economic reason why you would use fentanyl, and also there's a dynamic reason why you'd want to use fentanyl. That being said, however, fentanyl, as we all know, is very, very toxic and is really part of the opioid epidemic that is now ravaging both the United States and now also Australia. So, as you say, Philippe, fentanyl is probably the most dangerous adulterant that we know about.
Indeed. And as we've mentioned, it can lead to people being unaware sometimes that they've got fentanyl mixed in with their cocaine, and it can lead to opioid overdose, respiratory depression, and death, which is such an unforgiving drug, fentanyl, and it's so potent. So I guess, Virgil, we've talked a lot today about the acute toxicities with regards to cocaine. We've talked about the metabolites of cocaine, the different organ systems cocaine affects, and the adulterants that are commonly mixed in with cocaine, and the complications associated with that mixture. So it's been another action-packed episode of Cracking Addiction. Thanks for your attention and for joining us on this episode. And please do remember to like and subscribe to both the podcast and the YouTube channel. Thank you once again, and bye for now.